Okay, so I think we're going to go ahead and get started with our last session in Bayview B for the day and the course. So I'm here to introduce Dr. Faustine Ramirez, and she's a primary care sports medicine doctor who cares for pediatric and adult patients with a wide range of musculoskeletal conditions. She has special interests in musculoskeletal ultrasound, bone health, growth plate injuries, and care for adolescent female athletes. In research, Dr. Ramirez focuses on understanding how sports specialization affects mental health and burnout, bone health, and injury risk in young athletes. She also conducts research on improving musculoskeletal and sports medicine education for pediatricians. Dr. Ramirez has earned her medical degree and completed a residency in pediatrics at UCSF. She completed a fellowship in primary care sports medicine at Stanford University. And throughout her schooling, she was honored with several awards, including an award for her commitment to a career in sports medicine from the American Medical Society for Sports Medicine. During both her residency and fellowship training, Dr. Ramirez has provided medical coverage for many Bay Area sporting events at the high school and collegiate levels. At UCSF, she was team physician for Lowell High School and led educational workshops for student athletes on wellness, sports performance, mental health, and injury prevention. At Stanford, she served as team physician for many varsity sports. Dr. Ramirez was born and raised in San Francisco. As an undergraduate at the University of Washington, she was on the women's soccer team and served as captain her senior year. She is the perfect person to discuss RED-S and considerations for the primary care physician with you today. Please join me in welcoming Dr. Faustine Ramirez.
Thanks for the introductions and for the opportunity to talk about this topic. It's something I'm really passionate about, and I'm excited to share some insights with you. Last talk of the day in the conference, so thanks for hanging in there with me. So we'll get started today. I have no disclosures. So we're going to start out with a case today. This is a case of a 16-year-old female soccer player who presents to clinic with atraumatic right midfoot pain for several weeks. Pain is exacerbated during soccer and running, but more recently she started to feel pain with daily activities, including ambulation. She trains an average of 15 to 20 hours per week. So at this point, I'd like you to take a second to think about or chat with your neighbor briefly. What additional history would you obtain at this point? What are some key questions that you'd like to ask her and her parent? So I'll just give you a second to think about that. All right, so I'd like to start by introducing the concept of relative energy deficiency in sports, which I'll refer to as REDS from this point forward. So what is REDS? REDS is a clinically diagnosed syndrome of impaired physiological and or psychological functioning experienced by both male and female athletes that is caused by exposure to problematic, so either prolonged or severe, low energy availability. So we're going to take a second to dive into this concept of low energy availability. So what is energy availability? So this is a concept that is explained by the dietary energy left over and available for optimal function of body systems after accounting for the energy expended from exercise. So there's a fancy formula to calculate energy availability that you don't need to memorize, but it's energy intake minus energy expenditure divided by fat-free mass. So in other words, energy in minus energy out divided by fat-free mass. And energy availability can be optimal, or it can be defined as low energy availability. And so low energy availability is a situation where you have any mismatch between dietary energy intake, so energy in, and energy expended in exercise, so energy out. And this mismatch leaves the body's total energy needs unmet. And this leads to an inability of the body to maintain all the functions that are required for optimal health and also optimal performance for athletes. So this diagram, I'll take a second to walk us through it, but I really like this diagram. It was created by Dr. Nikki Kay. And you can see in the middle, we have the optimal situation where we have energy intake that's matched with energy demand. So there's the blue box at the top is energy demand for the training load. So that's the energy expended during training. And you have that dotted line at the top that represents the energy required for life processes. So those are the energy requirements for your optimal functioning of different physiological systems. And in the middle, you have a situation of adequate energy availability. In other words, energy in matches energy out, and you have, optimal functioning of these different health systems in the body. Now, it's important to remember that low energy availability can either be intentional or unintentional. And we talk a lot about intentional low energy availability because we think about restrictive eating and disordered eating, and we'll talk more about that. But it's important to remember that sometimes low energy availability can actually be unintentional. So starting with the intentional low energy availability, that's where we have a mismatch based on insufficient energy intake. So that insufficient energy intake does not match the energy expended in exercise, and that leaves us with reduced energy available for life processes. So here, this is often in the hopes that leaner body habitus might improve performance. There's various reasons why people intentionally restrict their energy intake, but this is the intentional scenario. But there's also an unintentional scenario where you have unintentional low energy availability, and that's often where there's excessive training or increased training load, and the energy intake is not increased to account for that increased energy expenditure. So here, the energy demands for training load exceed what the energy intake is, and again, we're left with reduced energy available for life processes, but this was done unintentionally because the energy intake was not increased with the increased exercise. So this is a concept of low energy availability, and it's essentially the underlying etiology for the REDS syndrome. And as we'll see in these next few slides, REDS can affect both various health systems and physiological systems, but also can have adverse psychological outcomes and also performance outcomes. So we're going to start by going over the adverse health outcomes, and then we'll go over the adverse performance outcomes. So this diagram here, I know it's probably a little bit small for you, but it's in your syllabus as well, and we'll discuss these. But this is the REDS health conceptual model, and it shows low energy availability at the middle. And you can see how there's arrows leading to all these different systems in the body that can be negatively impacted by low energy availability. There's just a unique scenario for mental health issues where there's a bidirectional arrow, and it's important to remember here that both mental health issues can both lead to the development of REDS, can be risk factors for REDS, and low energy availability can also lead to adverse mental health issues. So here the relationship is bidirectional and quite complex, but for the other systems, there's association between the low energy availability and these adverse outcomes in these different systems. So these include, but aren't limited to, impaired metabolism, hematologic function, immunity, cardiovascular function, reproductive function, gastrointestinal function, bone health, mental health, neurocognitive function, sleep, and musculoskeletal health. And many of you have probably heard of the concept of the female athlete triad and the male athlete triad. And that's because adverse, bone health outcomes and adverse reproductive health outcomes are probably some of the more studied adverse health outcomes of low energy availability. But that triad actually fits within this conceptual model. So this is more of an expanded model that includes the female and the male athlete triad, but is more inclusive of adverse outcomes on different health systems beyond just reproductive function and bone health. It also expands to include male athletes, and it also includes effects on performance. So REDS conceptual model is essentially, you can think about it as an expanded model that includes the female athlete triad, but goes a little bit further than that. And as you can imagine, with all of these different adverse health outcomes, this can lead to impaired well-being, increased injury risk, and it also can lead to decreased sports performance. So there's also a REDS performance conceptual model, and this is really helpful because I think for athletes, you can get more buy-in from them if you talk about the performance effects of low energy availability. They don't always want to hear about the adverse health effects, but if you can tell them about how this may affect their performance in a number of different ways, I think you can get more buy-in from them about why it's important to address low energy availability. So some of the adverse performance outcomes include decreased recovery, decreased training response, decreased cognitive performance or skill, decreased muscle strength and power, decreased endurance, decreased motivation, and decreased athlete availability, either due to illness or injury. So, more time on the sidelines, essentially. So with this framework, we're going to dive back into our case and we're going to explore some different aspects of this case. Briefly going over the prevalence and risk factors for REDS. The prevalence of REDS and low energy availability is really widely reported in the literature. Some of this has to do with limitations and how REDS is defined, low energy availability is defined, and then there's just a lot of variability based on the different sports and populations of athletes, the level of competition they're participating in. So these are really wide ranges, but they've been reported anywhere from 23 to 80% for female athletes and 15 to 70% for male athletes. And you can really see REDS in any sport, but there's higher risk among aesthetic sports. So thinking about dancers, for example, gymnasts, endurance sports, thinking about your runners, weight class sports like wrestling, for example, and really any sport that associates leanness or a thin body habitus with athletic success. But you can see REDS in really any sport, so important to keep a high index of suspicion. All right, so case continued. On further questioning, our patient reports menarche occurred at age 12. More recently, menstrual cycles have been sporadic. Over the past year, she has only had 3 or 4 periods. Prior to this, periods were regular, occurring once a month on average. Last menstrual period was approximately 4 months ago, and she is not taking any form of contraception. What is your differential diagnosis for these findings? So I'll take a second to think about that. What's on your differential here as a primary care provider or another healthcare provider if you're getting this history from your patient, whether it's in the PT office, in the primary care office, an athletic training room. These are questions you might be asking. And so think about what are some things on your differential here. For this specific part of the history, so for the menstrual irregularities. We'll get back to the foot pain. All right, so let's jump in and talk a little bit more about impaired reproductive function in females. So this is one of the more well-studied, well-researched detrimental effects of REDS. This can manifest as primary amenorrhea. It can also present as secondary amenorrhea, also called functional hypothalamic amenorrhea, or other types of menstrual irregularities or decreased libido. And some ways to screen as a healthcare provider is to take a detailed menstrual history. So that's going to include age at menarche, last menstrual period, number of cycles per year, duration of periods, duration of time in between cycles, use of contraception, and asking if periods were ever regular or have they always been irregular. And it's really important to take a detailed history because you may not get at some of the menstrual irregularities if you only ask, hey, are your periods regular? Yes. And if you don't follow up with, are you on birth control? Well, you might completely write off that patient who's been on an OCP for their whole athletic career and you have no idea if they're having menstrual irregularities. Or, if you don't ask if periods were ever regular, then maybe you're looking at more of a primary amenorrhea situation. Or so there's a lot of information to gather here, and it's really important to normalize this with your athletes. The way I do this is one, I try to establish a link. Why is this question important first? We know that there's a link between your reproductive health and other aspects of your health, like your bone health, your metabolic health. All these aspects are an important part of your health as an athlete and your performance. And so that's why I'm asking these questions, so it doesn't seem totally random and intrusive. And then just following up with, this is something I ask of all of my female athletes, and that way you can really normalize it. And so what are some of the next steps in management for the primary care provider? So first you want to do a workup to make sure that you're excluding other causes of either primary or secondary amenorrhea. We don't want to just write this off, say this is REDS without doing a further workup, and making sure we're not excluding some other underlying condition, and referral to endocrinology if it's indicated, or if you'd like some assistance in doing that workup. I find it helpful to check an estradiol level. I'll talk a little bit more about what labs I would obtain at the end, but that's definitely something to include as part of your workup. And if you've excluded other causes and you're concerned about functional hypothalamic amenorrhea, you can refer to a primary care sports medicine specialist for a full REDS evaluation. It's important to remember, and one aspect of the REDS concept is that it expands to male athletes as well. So there's been a lot of, we focused a lot on female athlete triad, but it's important to remember that you can have impaired reproductive function in males as well. So some of the manifestations of that are reduced testosterone levels, erectile dysfunction, decreased libido. And there's some screening questions that you can ask to help get at these manifestations. So you can ask about a history of low libido. You can ask about decreased morning erections, and you can also ask about whether they have been needing to shave their facial hair less frequently. And those are some screening questions that have been established in the male athlete triad consensus statement. And then in terms of next steps for the primary care provider, again, you're going to do a workup to exclude other causes of hypogonadism, refer to endocrinology if indicated. As part of that workup, checking a total testosterone level, and then referring to primary care sports medicine for a REDS evaluation if you've excluded other causes. All right, so moving on with our case, let's get a little bit more information. So our patient also reports recent difficulty sleeping over the past few weeks. She has been more anxious and stressed out as she is concerned about her ability to participate in her upcoming soccer tournaments due to her foot pain. So we're seeing here some potential mental health implications. So let's talk a little bit about mental health issues and how they relate to REDS. So as I mentioned at the beginning, mental health issues are both risk factors and consequences of REDS, and are more prevalent in female compared to male athletes. So potential manifestations, we might see clinically diagnosed mood and or anxiety disorders. We might see disordered eating behaviors and eating disorders. Or we may see psychological symptoms that don't meet a clinical diagnosis for a DSM psychiatric condition, but are still related to mental health. So thinking about depressive symptoms, increased stress, anxiety symptoms, mood changes, sleep disturbances, or body dissatisfaction or body dysmorphia. So screening for healthcare providers, you can use formal screening tools like the PHQ-2, PHQ-4, the GAD-7 that you're all familiar with, or just taking a focus history and asking some follow-up questions about these symptoms if you have concerns. In terms of next steps, here it's really going to be referral to mental health services, whether that's a psychologist or a psychiatrist or a behavioral health team in your clinic, to help support the patient regarding these symptoms and potentially, diagnose them if you're worried about a diagnosis in the mood or anxiety disorders. Okay, so case continued. Now we're taking a more focused dietary history, and the patient reports a sensitivity to gluten and dairy. So she avoids gluten-containing foods and dairy most of the time. Otherwise, she reports eating a well-rounded, healthy diet, and she eats clean. She sometimes misses dinner because soccer practice occurs at the same time as her family's dinner time. And she denies intentionally restricting her intake or skipping meals. So here, what features of this dietary history are concerning to you? So I want you to, pick out a few items on this history that raise some red flags for you when you're getting this history from the patient. All right, so let's talk a little bit more about disordered eating behaviors and eating disorders. So I'm differentiating these because I think it's important to recognize that there are disordered eating behaviors that exist on a spectrum between optimized nutrition and a clinically diagnosed eating disorder. And so you can see on the diagram here on the left, optimized nutrition is safe, intentional, healthy eating behaviors that balance health and performance. And then all the way on the right, you have behaviors that meet DSM-5 criteria for eating disorders. And then, in the middle between those two, you have really a wide range, a wide spectrum of behaviors that are not totally healthy and optimized, but don't quite meet diagnosis for an eating disorder. And many athletes exhibit some of these disordered eating behaviors, and they don't quite meet that diagnosis for an eating disorder, but you're still really concerned, and there's some red flags when you're hearing about their dietary practices. And so this spectrum is quite wide, and many athletes fall along the spectrum. And disordered eating behaviors and eating disorders are really important to recognize because they're risk factors for the development of low energy availability and therefore risk factors for the development of REDS. So screening for healthcare providers, this is where taking a focused dietary history is really important. And some ways to get at this, because the athlete may not be totally forthcoming with you, is to ask about any special diets that the patient follows. Do they avoid any specific food groups? So maybe they follow gluten-free diet, but they don't have celiacs, and or maybe they follow low carb or a low dairy diet or vegetarian or vegan, and you want to respect their dietary practices. Many people are vegans or vegetarians. For some, it's cultural reasons, spiritual reasons. For some, it's just personal choice. But in an athlete, you also want to keep that in mind as a potential red flag. And there's been studies that have shown there's an association between following these special diets amongst athletes and disordered eating behaviors. So we know that those can be used as like a screening question. You want to ask about number of meals per day. Are they eating breakfast, lunch, and dinner? Are they having snacks? Are they fueling before their training, fueling after their training? What does the composition of these meals look like? Is it a plate full of salad? They say, yeah, I eat 3 meals a day. Well, what does that plate look like? Is it well balanced? What does it include? Protein, carbs, vegetables, fruit, or is it only lettuce and carrots? Do they have any weight concerns? So are there internal concerns that they share or external concerns? Is a coach telling you need to weigh a certain amount? Is a parent or a teammate telling you need to weigh a certain amount? There's, social media telling you need to weigh or look a certain way. That's a whole nother can of worms that we're not going to open today. Do they worry about their weight? Do they have a history of calorie counting? And if I'm getting red flags throughout the history or some things that don't feel, totally healthy, then I will specifically ask if they are intentionally restricting. So if they tell me they're skipping meals or they're not fueling as much as I think they should be based on their exercise, then I'll specifically ask them. And some athletes will be honest and some won't. And then if you're going down that path, you can certainly ask if there's any history of binging or purging or use of laxatives, diuretics, but I don't usually need to get to that. Usually these questions are sufficient. But if they do have a history of an eating disorder, that's also a red flag and a risk factor for the development of low energy availability. And I think these questions, without getting too intrusive, are sufficient to get a sense of nutritionally what's going on with the athlete, as long as they're being honest with you. Sometimes with adolescents, parents in the room, I think could actually be helpful because the parents are a nice balance where they provide conflicting information to what the adolescent is providing. And so it gives you a little bit of a sense of what's going on. But you can always choose to talk to the adolescent individually as well. So in terms of next steps for the primary care provider, if there are concerns, you can refer to a dietitian. If ideally a sports dietitian, but any dietitian can help with that initial evaluation. And then a referral to primary care sports medicine for a REDS evaluation. And if you're concerned about an eating disorder, you want to include a behavioral health team and an eating disorder specialist for that evaluation and further management. All right, so case continued. On review of systems, the patient reports low energy, fatigue, and cold intolerance. Prior to the onset of foot pain, she had noticed a decrease in her soccer performance, including easy fatigability during games and longer recovery between training sessions. Physical exam reveals a resting heart rate of 50. So what blood work, if any, would you obtain at this point? I'm going to pause there so you can think about it. Yeah, okay, great. Okay, so I'm going to dive into a few more adverse health consequences of RED. So first, I'd like to talk about impaired energy metabolism and regulation. So some of the potential manifestations of this include either a subclinically or a clinically low T3, a low resting metabolic rate, increased cortisol. How do you screen for this? This is really hard. There are very non-specific findings that you can ask about that have a very long differential for them. So I think this can be pretty challenging when you're trying to pick up on this. Some of the things you might consider asking about are fatigue or low energy, but as you know, there's a super long list of things that this could be. So you're going to have to ask some follow-up questions. In athletes, you think about mono, you're thinking about infection, you're thinking about underfueling, you're thinking about poor sleep, mental health issues, other endocrine conditions. There's a really long list of things that you you could be thinking about for fatigue or low energy in an athlete. So very nonspecific. Cold intolerance, you're getting a little bit more thinking about those hypothyroid symptoms. Skin and hair changes, so dry skin, brittle skin, same thing with hair. You can ask about constipation. You can see if they have a low resting heart rate. You can see on their vital signs if they have, I didn't put it here, but hypotension, orthostatic hypotension, if they've had mood or sleep changes. But again, these are all very nonspecific symptoms, so this can be a little bit challenging. But it's really going to be the constellation of findings. If they're answering yes to all of these questions, that should raise your index of suspicion. So next steps in terms of blood work. So this is going to be one portion of it. A total T3 can be a really helpful lab to obtain, as well as a TSH with a reflex T4. You want to exclude other causes of hypothyroidism. Consider a referral to endocrinology if there are abnormalities on these labs, or if there are other red flags for you on your history and physical. And then again, after excluding other causes, thinking about a referral to primary care sports medicine to do a complete REDS evaluation. Then we'll also talk about impaired hematologic function. So when you're thinking about low energy and fatigue, again, anemia is going to be on your differential as well, and that's a whole nother system that could be impaired in REDS. So this might manifest with low iron, low ferritin, reduced iron absorption, a low hemoglobin, and you may see a low ferritin even in the absence of anemia, and that could be an indication to supplement with iron, which I'll talk a little bit more about. So screening for healthcare providers here, you're going to ask about a history of anemia or look at their previous blood work, asking about fatigue or low energy, lightheadedness, headache, symptoms that are typically associated with anemia. And then important to ask also, do they have any dietary intake of iron, whether that's through heme or non-heme sources, and then whether they take an iron supplement. Here, you're going to be thinking about getting a CBC, iron studies, and ferritin. I would get all of these because you may see low ferritin with the absence of anemia, and you also want to see what the iron studies are doing. You may consider additional labs if there is anemia to work up the anemia, just to not write it off to REDS, without excluding other causes of anemia. And then you can consider iron supplementation, and I'll talk a little bit more about that next. So looking at iron supplementation. So the table here shows the recommended daily allowance for iron in different age groups and different populations. And you can see it's very variable. And in athletes, it's likely higher. We just don't have well-established guidelines for athletes. There are different formulations. Some of these are available over the counter. Some of these you can prescribe. And a few considerations if you're going to be supplementing with iron. So heme iron is better absorbed than non-heme iron if the patient is trying to supplement just with their diet. Calcium and dairy, as well as acid blockers, can interfere with absorption. So if your patient is also on a calcium supplement or eating foods that are rich in calcium or taking an acid blocker, you want to try to separate those by 3 or 4 hours. You can consider taking vitamin C at the same time as the iron to aid in absorption. And because one of the main side effects is constipation and GI side effects, you can actually just dose this 3 times a week, like Monday, Wednesday, Friday. And there have been studies that have shown similar increases in your ferritin with just 3 times a week dosing. So it's not necessary to supplement every single day. And that can help with some of the managing the side effects. And you can use ferritin levels to help guide supplementation. This is especially going to be in the setting of low ferritin in the absence of true anemia. And so different studies have suggested different levels. Some studies have suggested 35 as the lower limit of normal in athletes. But there are some studies that suggest higher levels, like greater than 40 or even greater than 50, especially in endurance athletes. So this is where, you might get a ferritin that's 20, and that may not flag as abnormal in the reference range, but you know that that's pretty low for an athlete. And if it's an endurance athlete, you're going to be seeking to bring that up much higher. And this is definitely something we can help with in primary care sports medicine. If you don't feel comfortable guiding that supplementation, this would be a perfect example of something that I might do in primary care sports medicine clinic. Okay, so case continued. On musculoskeletal examination, she has no effusion or swelling. She has full pain-free ankle range of motion and strength, a stable ligament examination, and focal tenderness to palpation over the navicular, a non-antalgic gait, and pain with a single leg hop. All right, think about for a second, what's your leading diagnosis at this point? and what your next steps might be. All right, so let's jump in and talk about impaired bone health, which is one of the most well-studied adverse health outcomes of REDS. So some potential manifestations are going to be impaired bone mineral density and lack of expected peak bone mass accrual in adolescence during the time of peak bone mass establishment. So REDS is really important to identify in our adolescents because this is when they have their highest peak bone mass establishment. And if they're experiencing and going through REDS during this time of peak bone mass establishment, they may not have the bone mass accrual that they should be having during this really critical time period. And that is, can lead to really long-term outcomes for them in terms of osteopenia and osteoporosis for the rest of their life. And so this is really critical to identify and try to prevent this from happening during, adolescence. And then bone stress injuries if they've gotten to the point of having, a bone stress reaction or even a stress fracture. So in terms of screening for healthcare providers, do they have a history of bone stress injuries, even just milder bone stress reactions? Have they ever been diagnosed with low bone mineral density? And getting a good dietary history, asking about intake of dairy and other foods that contain vitamin D and calcium. In terms of next steps for the primary care provider, checking a vitamin D level if they have not had one recently, starting vitamin D and calcium supplementation. I'll talk a little bit more about that next. And then if you have concerns about their bone health, even in the absence of a specific injury, you can refer to primary care sports to do more of a bone health optimization workup. So that might include a DEXA, getting labs, talking about supplementation, and more severe cases, consideration of transdermal estrogen. Or if you're concerned about an actual injury, like a bone stress injury, that would be another reason to refer. So in terms of vitamin D supplementation, the RDA in children and adults up to 70 is 600 IUs daily, and in adults 71 and older is 800. In athletes, it's likely higher. The guidelines are not well established here, but considering closer to 1,500 or even 2,000 IUs daily as a preventative supplementation, it would be higher if you had a patient with a bone stress injury or if you were treating vitamin D insufficiency, it would be higher based on the vitamin D level. But just from a plain supplementation standpoint, we're still likely looking at higher levels than the RDA in the general population. The vitamin D levels can help guide supplementations. Again, optimal levels are not well established, are likely higher in athletes. So that reference range that the lab is giving you, although that may be a good reference range for the general population, you're likely looking at a higher level for athletes. And the Female Athlete Triad Coalition recommends a level between 32 and 50. That's still a pretty big range. And depending on what resource you look at and what sports medicine physician you talk to, they might have different recommendations, but it's likely higher than what the lab is telling you is the lower limit of normal. Dietary sources of vitamin D are pretty limited. So fortified milk, cereal, orange juice, some fish, but 90% of our vitamin D is obtained through sun exposure. And considerations for supplementation, D3 is thought to be superior to D2, and low magnesium can cause resistance to vitamin D supplementation. So if you've been supplementing one of your patients and their levels are not increasing, consider adding a magnesium supplement to see if that will help. And calcium supplementation, this table here shows the RDA based on age. Again, in athletes, the RDA is likely higher, but guidelines are not well established. But probably looking at 1,000 to 1,500 at least, and maybe higher depending on the situation. Here, there are some dietary sources: dairy, certain fish, certain leafy greens, and then fortified orange juice and cereals. There are some considerations again. So remember, thinking back to our iron, to separate calcium and iron supplementation by 3 or 4 hours. Absorption is greatest with food and kind of maxes out at 500 milligrams. So if you're supplementing 1,000 or 1,500, you're going to need to split those up. If you're supplementing more than 500 at a time, it's likely not getting absorbed. So that's important. And higher intake has been suggested in athletes with REDS, closer to 1,500 milligrams per day, but that has not been well established in the literature. Okay, so case conclusion. So I'm going to tell you a little bit how I would approach this case for each of the problems. So for her midfoot pain, I'm concerned about a navicular bone stress injury. So I would get an x-ray, I would get an MRI to evaluate for the bone stress injury, and I would recommend complete cessation of all impact activities while we're waiting for the MRI results. And I would immobilize her in a cam boot. And because the navicular is considered a high-risk bone stress injury, I would make her non-weight bearing while awaiting the MRI results. Most higher risk bone stress injuries have a period of time when they're non-weight bearing, and I would just start the clock right away. She will thank you for that later when she's already been non-weight bearing for several weeks by the time you get the MRI results. I would start vitamin D and calcium supplementation, and then I would get the lab, the vitamin D level, and then I would adjust the supplementation based on what that level shows. For her secondary amenorrhea, I'm concerned about functional hypothalamic amenorrhea. Here I would get an estradiol and a TSH with reflex T4. But if she hasn't had a prior workup, I would either have her PCP do a workup as well. Things you might consider, rule out a pregnancy, prolactin, LH, FSH, and a total testosterone, thinking about PCOS and other causes of secondary amenorrhea. Either, the PCP or myself, someone needs to do that workup just to ensure that we're not missing something else, and we don't want to anchor just on REDS despite all these other features. Her disordered eating behaviors and sleep and mood disturbances are concerning to me for mental health issues related to REDS. I would do some nutritional counseling. I would also refer her to a sports dietitian and to a sports psychologist. And her fatigue and low energy are concerning for either impaired energy metabolism and or impaired hematologic function in the setting of REDS. Here I would get a CBC with differential, a ferritin, iron studies, a total T3, and a TSH with a reflex T4. I would consider iron supplementation based on her lab results and a referral to a sports dietitian to address the underlying low energy availability. So thinking about treatment for REDS, really the mainstay of treatment is going to be restoration of this optimal energy availability. And that's going to include dietary and exercise interventions. We know that dietary interventions play a larger role here in the treatment of REDS than exercise. Part of that is because we try to keep our athletes engaged in their activities as much as we can. So it's a lot easier to increase your intake as an athlete than to tell your athlete that they need to participate less or reduce their amount they're exercising. You're not going to get a lot of buy-in if you tell them they need to stop exercising as much. So I think it's a lot easier to, address this by increasing your energy intake. And they'll usually be on board with that as opposed to shutting them down. Although, depending on the injury, you may need to. And sometimes in more severe cases, we do need to restrict their activity level. But we try to keep them engaged and involved as much as possible because that's important for, their overall well-being and, their overall recovery. And then if there is a specific body system dysfunction, like we talked about, hematologic dysfunction, metabolic dysfunction, you can address that individual system. But really the key part of treatment here is going to be to restore that energy availability. And so you have to work with your sports dietitian and with a multidisciplinary team to address this. And in terms of prevention, primary prevention is really going to hinge on education of adverse health and performance outcomes of REDS amongst athletes, coaches, and coaching staff. So you can all go back to your communities and share this information and spread the word and raise awareness because that's where primary prevention comes from. Secondary prevention is also really important because, this is a spectrum. And if you can catch things early and identify REDS symptoms early, you can intervene early. So perhaps you can intervene on the patient with poor bone health before they develop the bone stress injury or before they develop the secondary amenorrhea. And you can intervene early with these different modifications that we talked about. These are my references, and I'd like to put in a quick plug for our Pediatric Musculoskeletal and Sports Medicine Conference coming up in March. And I don't know how much time we have, but I'm happy to take any questions. Yeah.
So I have a friend son who's an NCAA swimmer.
Yeah.
And how do you kind of hedge this off with a non-weight bearing sport that maybe not have these bone issues and other things? It got to the point where he didn't perform well at NCAAs or something like that. Like, how could we have found it earlier?
Yeah, I mean, I think the performance aspect is key. Like if there were any signs of performance impact earlier on than, the NCAA's, that could have been something to explore. Like, why are you not performing well? Are you feeling tired? Kind of exploring that a little bit further. And then those subsequent questions about, on that metabolic dysfunction slide. So are there other signs of metabolic dysfunction, fatigue, low energy, poor performance, and then that constellation of symptoms? The more you ask, the more things might arise. And so I think it's really, exploring, asking a lot of follow-up questions and trying to dive a little bit deeper. I don't know what other symptoms he had or what other, if there was anything at all that could have been a clue to this, but.
They definitely have the low testosterone. He wasn't losing weight, but they were overtraining him. And they just said, well, maybe we just overtrained you and you just swam poorly.
Yeah.
They blamed it on mono.
Yeah.
I think it's often misdiagnosed, no?
Absolutely. Yeah. And I think, mono definitely comes up a lot on the differential for collegiate athlete with low energy fatigue. But there's a lot of overlap between overtraining syndrome and REDS. We know that a lot of overtraining is actually, or overtraining syndrome is poorly diagnosed as overtraining syndrome, but the root cause is low energy availability for a lot of patients, and that just hasn't been correctly identified. Yeah. Yeah.
What are your thoughts on intravenous iron supplementation for folks with iron deficiency without anemia, like athletes with or without REDS?
Yeah, I think it's not typically necessary. I think you can accomplish that goal of increasing the ferritin just with oral supplementation.
And then if you're not like that.
Yeah, you can eventually consider it if they're not getting it up. Yeah.
Folks are using it.
Yeah.
Anemia.
Yeah. Yeah, I think there are a lot of coaches that are telling, their cross-country athletes that they need their ferritin to be above 50, and so they want to get that result more quickly, but I don't think it's necessary. I've seen that as well in kind of high school cross-country populations, but I think oral supplementation is sufficient, and you just can keep monitoring it. Every 6 to 8 weeks, you can check it. Yeah. Yeah.
I was wondering how weight factors into your assessments, and like if the adolescent patient is weight the same or maintaining your BMI, is that reassure you or not necessarily? And then the second part of that is if they are like just traditionally low BMI throughout their whole life, but that over potential is, or they have higher risk on this.
Yeah, so I think it depends what the BMI is. If it's, if it's an unhealthy or very low BMI, even if they've been maintaining that, I'm concerned about it. And if they are maintaining a BMI but have all of these other factors that are concerning for REDS, losing weight would be a more advanced case. In other words, if they weren't able to maintain that weight, that would be a more, extreme end of the spectrum. And so if they have all of these other factors that are concerning to me, it's the number itself for the weight, or doesn't matter as much as all these other features. But there are, if depending on what the BMI is, could be concerning. Like if it was, less than 18 in the 17 and a half, that in of itself is concerning. Yeah.
Do you have a cutoff for when you would do a DEXA scan for any
so I think it depends on a number of factors. The number of bone stress injuries they've had, if they have a history, how many bone stress injuries have they had? What has the amenorrhea history been? There are some guidelines on, and I don't have them all memorized, but there are some guidelines on like kind of risk assessment tools that can give you guidelines on when to obtain the DEXA, especially when there's been multiple what we call high-risk bone stress injuries. I'm certainly more likely to obtain a DEXA. I think, if you're considering transdermal estrogen for bone health optimization, that's certainly an an indication, you'd want to get the DEXA first to see if it's going to be indicated. Work closely with your endocrinologist. That's not something that I prescribe, but I would work closely with the endocrinologist regarding that. There are some specific criteria that you can use, like different risk assessment tools, and I'm happy to share those with you afterwards. Yeah.
What are other high-risk bones factors in the report?
Sorry, what was?
High-risk areas of stress fractures.
Okay, so talus, navicular, femoral neck, fifth metatarsal. Trying to think here. What's that? Yeah, anterior tib. Yeah, but, pelvis is controversial. Some people consider it high risk, some people consider it low risk. Calcaneus, also controversial. Some people consider, but yeah, anterior tibia as opposed to posteromedial tibia. Let's see, all my other sports med colleagues, feel free to weigh in here. I think those are the main ones. Yeah, I think, mostly lower extremity. And it's good to keep in mind because, to have, a list that you can reference at least in your notes, because those would be ones that you would want to put, make non-weight bearing right off the bat, because they would be treated with a period of non-weight bearing mobilization. Yeah. Okay. Other questions? Awesome. Okay, thanks everyone.